Good morning, ladies and gentlemen. My today's lecture is in continuation with my previous lecture. All those who have seen my previous lecture must have noticed that what I was trying to impress upon you, and I'm going to do the same again in this talk. The purpose of my talk is to make the clinical diagnosis for you easy. And in order to make the clinical diagnosis easy, we are going to divide the different skin diseases into certain syndromes. And once we give the syndrome its label or we find the specific feature of that syndrome, then we can further discuss and think upon it that what are the distinguishing features of a specific clinical disease. So, to make the diagnosis easy, it is better to first place uh, a particular disease into a syndrome and then going into detail and then making the clinical diagnosis. I am Professor Asher Ahmad Mashood and I am from Pakistan. So, we are now going to discuss syndrome number 17, and that would be the sporotrichoid spread. By sporotrichoid spread, it means that spread of nodular lesions along a linear line, and this spread is through the lymphatics. So, all the infections which spread through lymphatics will give this appearance. And the first picture is that of sporotrichosis, from which the term is coined. And sporotrichosis is a kind of deep fungal infection. And you can see that where the fungus has entered is the biggest nodule. And in addition to that, along the lymphatic drainage, there are two other nodules. So this is sporotrichosis. Another very common infection, sporotrichosis is not a common infection, but this is a very common infection and seen in endemic areas, and this is cutaneous leishmaniasis. Again, the biggest lesion is the most distal one, and the proximal are those baby lesions which occur along the lymphatic spread from the main lesion. So this is cutaneous leishmaniasis. So if you find a patient with such kind of presentation, the first diagnosis should be cutaneous leishmaniasis and not sporotrichosis. Another condition in which the lesions develop in a sporotrichoid manner are the atypical mycobacterial infections. It can be Mycobacterium marinum, Fortinum, cloni. There are several atypical mycobacteria which also form lesions in sporotrichoid fashion. Syndrome number 18 is the neuropathic ulcers, the ulcers which are not painful, rather numb. So, the typical feature of a neuropathic ulcer are large ulcer with very clean base, no hint of any bacterial infection, and a very thick callus surrounding the ulcer. So, treating these ulcers are quite difficult because they are from the onset, they are quite deep, and you require multiple dressings and pressure avoidance. So there are two common conditions which result in neuropathic ulcers. The first one is diabetes mellitus, which results in numbness of hands and feet, or if the patient is having such kind of ulcers, when you will ask, the patient will give the history of numbness on the feet, resulting in ulcers which gradually enlarge, and the patient is very less aware of these ulcers. And a similar condition is lepromatous leprosy, where there is a glove and a stocking anesthesia, and patient develop ulcers. So again, these two conditions result in neuropathic ulcers, which are quite difficult to manage. Sometimes we even resort to skin grafting. The syndrome number 19 would be the linear lesions. All the skin diseases which presents as linear lesions will come into this syndrome, And the first is you can see that there are several linear marks which looks like scratch mark, but actually this is the flagellate dermatitis. The flagellate dermatitis is because of shiitake mushroom ingestion or by ingestion of bleomycin, which is an anti-cancer drug. Then this is a phytophotodermatitis, all those outdoor workers who are working with plants. They present as linear contact dermatitis type lesions, which is because of the contact with plants, which have some photosensitive chemicals in it. This is a kind of congenital issue, congenital problem. Patient present with linear lesions of which are usually unilateral or give a Chinese letter appearance as well. So this is a verrucous epidermal nevus. A linear lesion with a bit hint of eczema, little bit of oozing, some vesiculation, some excoriations. So this is lichen striatus. Then the linear lesions which have a hint of violaceous pigmentation, it is the linear lichen planus. Then the linear lesions with the scales and erythema, this is linear psoriasis. So all the linear lesions are grouped in syndrome number 19, now syndrome number 20, which is papulonecrotic lesions. So those lesions in which papules have a central necrosis. So the first is the very common acute infection, which would never come in the exam. This is the chickenpox, and the typical part in chickenpox is that the lesions are pustulo-necrotic lesions. There are no papules, and the lesions are at different stages of healing. Then a very similar but a chronic conditions, it is pityriasis lichenoides et verruliformis acuta, which presents as papular lesions, as necrotic lesions, as PIH. Patient is usually sick with fever, and it is not very acute. It's not neither very chronic. It is, but not like chickenpox. It is not in days. The disease develop in days. This is a condition which is of exam case, and it will be commonly presented. You will see that the lesions have a necrotic center, and one of the very common diseases here is the papulonecrotic papulonecrotic tuberculosis. Um, I am, just give me a second. Yes. This is another condition which comes in the differential diagnosis of pleva. Again, present as the papulonecrotic lesions and will also be in differential diagnosis of other papulonecrotic condition. This is lymphomatoid papulosis. This is histologically looks quite malignant, but the course is quite benign. This is not a very uncommon condition and seen in patients with chronic renal failure. You can see the lesions with an papular lesions with a necrotic center. This is reactive perforating collagenesis. So from the papulonecrotic conditions, we are now moving to syndrome number 21, and this is those skin diseases in which there are sinus formation. There are not many conditions associated with sinus formation. The first and the very common is scrophloderma, which is a kind of tuberculosis, and seen mainly on the bone and on the lymph nodes. And this is mainly on the lymph nodes. Then this is again a lot of sinuses formation, nodular sinus formation, and this is actinomycosis. Another case of actinomycosis in which the sinus formation are seen in axilla. A closest differential is hidradenitis, but hidradenitis will be associated with abscess formation, not sinuses. This is mycetoma foot, can be actinomycetoma or can be eumycetoma, And again, this develop on the bone, resulting in osteomyelitis, chronic osteomyelitis. Chronic osteomyelitis would also result in sinus formation. So, on all the diseases which are associated with sinus formation, they develop usually on the bone or develop on the lymphatics, lymph nodes. And the common differential is tuberculosis, actinomycosis, or actinomycetoma. Syndrome number 22 is that of vesiculobullous and crusted lesions. And the first condition is acute eczema. You can see you can see some vesicles and some bully and erythema, background erythema, some crusted lesions. So no particular pattern. Then it is acute eczema. Then such kind of lesions, when develop on hands and feet, the vesicles are small. This is called as dyshydrotic eczema or Pomphylix eczema. Can develop on hands and can develop on feet. Grouped vesiculopustular lesions. This is herpes. It can be herpes simplex. If it is in a dermatomal pattern, it can be herpes zoster. Now here you can see a large area where there are blister, there are superficial erosions and crust. This is bullous impetigo, usually seen in young individuals, children. Now marching to syndrome number 23, it is the bullous lesions. Patient presenting with lesions with blister more than 1 centimeter. So now you have to differentiate whether the blisters or bully are flaccid or they are tense. Flaccid bully are seen in those skin conditions where the blister is intraepidermal. And tense blisters are seen in those conditions in which the blister is subepidermal. That is, the whole epidermis forms the roof, and that's why the blister is tense. So the flaccid blisters are seen in typically in pemphigus group of diseases. So one of those is IgA pemphigus, which presents as linear lesions. There are superficial vesicles, blisters, and erosions. Then the very common pemphigus vulgaris lesions are suprabasal. There are large blisters, erosions, crust, and everything. Then we come to bullous pemphigoid. Now you can see that in comparison to these blisters which were flaccid, these are the tense blisters on the background of erythema. There are few erosions as well. The lesions are itchy. This is a cryo-induced tense blister. So cryoblister. Blisters are seen on the extensor surfaces. There are erosions as well. They're quite an itchy condition, and it is dermatitis herpetiformis. The blister is in a form of small papillary tip microabscesses. Then these are the large tense blisters with lots of scarring. So the differential diagnosis of blisters with scarring is epidermolysis bullosa acquisita, and then it is porphyria cutanea tarda or other kind of porphyrias, and cicatricial pemphigoid. So blisters with scarring, these are the three differential diagnoses. Now marching to syndrome number 24. This is the targetoid lesions. Only erythema multiforme is not a disease which is associated with targetoid, but it is the most commonly known. And you can see that there are flat papules or plaques with central necrotic area. So this is giving a targetoid appearance. This appearance is also seen in linear IgA disease, in which there are annular vesicles or blisters and central eroded area. And this is also seen in herpes gestationis, which is a bullous pemphigoid-like condition seen in pregnant women, with associated again with annular vesicles or blisters with central erosions. And this is an insect bite reaction. The big blister in the center is the bite mark, and surrounding is variable shades of pigmentation. Now coming to syndrome number 25, and this is an acute rash with epidermal necrosis. These are generally the medical or skin emergencies, and patient present with the generalized dusky erythema on whole of the body, and some areas you can see flaccid blisters. Then the skin peel off and forming large erosions, and it is the Steven-Johnson syndrome or toxic epidermal necrolysis. This is a condition in which there are oral erosions and necrotic crusted lesions. The appearance is a mixture between pemphigus and toxic epidermal necrolysis, and it is a paraneoplastic pemphigus, which is seen in patients with suffering from long-standing cancers. This is a condition which is called hyperglucogonoma syndrome or necrolytic migratory erythema, and seen mainly in the flexures. Lesions are mainly annular, but there is lots of necrosis as well. This is seen in young children, especially when the weaning is complete from the mother milk. And this is acrodermatitis enteropathica because of zinc deficiencies. The lesions are seen in the flexures and perioral areas on the palmar creases. So there are many manifestations. Now, syndrome number 26 is an acute rash with pustules. Acute pustular rash. You can see this pustular rash on the body with background erythema. The patient is quite seriously ill. This is von Sombish or generalized pustular psoriasis. A similar condition developed as a result of drug reactions to penicillin or other drugs and with fever, and this is acute generalized exanthemic pustulosis or AGEP. Severe form of chickenpox will also present as acute pustular rash, and especially in patients who are immunocompromised. So, coming to syndrome number 27, we are now discussing the non-blanchable erythematous vasculitic lesion. So, the differential diagnosis of vasculitis would be in this syndrome. This is the generalized um, non-blanchable erythematous rash, and if you palpate it, there will be some substance on palpation, and this is leukocytoclastic vasculitis, mainly seen on the legs and may also be seen on the forearm. This is again a purpuric rash, non-blanchable erythema, but they are not raised, flat, and this is purpura due to any cause. Some time it's a clotting deficiency, clotting diseases, and sometime it is the deficiency of platelets like idiopathic thrombocytopenic purpura. Then this is DIC leading to large ecchymotic areas on the body. Again, it is because of deficiency of clotting factors leading in diffuse hemorrhages. And this is a very common infection seen in Asian population and in particular months, and it is the dengue hemorrhagic fever resulting in platelet deficiency and overall hemorrhages. This is a very common condition and it's called as the Schamberg's disease or pigmented purpuric dermatosis, seen on the legs mainly, and in those individuals who tend to stand a lot and have a poor hypostatic circulations. Syndrome number 28. We are going to discuss the ulcerated nodules on the shin. So there are particular few diseases which are associated with this kind of representation. The first is you can see here there are erythematous plaques, and on the center of them there are certain ulceration or erosions, and this is paniculitis due to any cause. Uh, there are central necrotic plaques on the shins, which give a yellow orangish hue. It is necrobiasis lipoidica, a common condition in chronic diabetics. Then this is a lot of ulcerated lesions on the leg and on the thigh, and this is factitious paniculitis by giving certain injections like pentazocine or other habits. These are ulcerated lesions, plaques, and the surrounding skin is not healthy. It is showing hyperpigmentation, and it is showing atrophy and some little bit of livedoid pattern. This is cutaneous pan, polyarthritis nodosa. The patient is obese on the wheelchair. These are the necrotic plaques and ulcers on the back of the shins, on the calf mainly, and this is erythema induratum, which is fine kind of paniculitis with granuloma formation. Pyoderma gangrenosum can occur anywhere, and these are the ulcers which are showing lots of necrosis and looks like infection, but no bacteria is grown here, and there is a particular management which you should all know how to manage such kind of cases. Now coming to syndrome number 29, this is a syndrome with hypopigmented lesions. Lots of diseases come in this category. This is a common presentation in young growing children, both girls and boys. And this is pityriasis alba. It's a kind of eczema due to dryness and sun sensitivity. Then this is geometric. This is a hyperpigmented patch with angulation, and this is not convex like vitiligo, and this is present since um, early life, and it usually persists in the same size or grows with the size of the increase in the size of the body, and this is nevus depigmentosus. There is no management, it cannot be treated, so it stays like that. Then comes the common depigmented depigmented patches can occur anywhere, and this is vitiligo. Then this is nevus animicus. It's kind of vascular nevus with hyperplastic or hypersensitive blood vessels leading to vasoconstriction. If you try to scratch the lesions will these hyperpigmented lesions will not take up erythema. And if you press with glass slide, which is called as diascopy, then the rest of the surrounding area will merge with this hypopigmented area. This is a fungal infection, pityriasis versicolor. If you look closely, there will be a little bit of scaling, and all the other variations of skin color may be seen here depending upon the skin color of the patient. This is a condition which should not never be ignored. Lots of hyperpigmented lesions on the trunk of young adults. This is hypopigmented mycosis fungoides. It has a good course, a benign course, um, and it is usually seen in young adults. Syndrome number 30. The pigmented lesions. We discussed the hyperpigmented. Now let's discuss the pigmented lesions. A very common condition seen in fair skin individuals, especially those with fair skin and red hairs. These are the freckles, a sun-induced lesion, and the only treatment is sun avoidance. Then in old age, you can develop the freckle-like pigmentation, but these are isolated, small to large lesions, flat. This is a lentigo, a solar lentigo. Then a very common condition seen in Asian skin, this is melasma, mainly on the malar areas, on the forehead, on the upper lip, on the nose. This is nevus of Ota, in which there is bluish pigmentation on the cheek, also involving the eye, the sclera. If it develops in the adult life without eye involvement, it will be called as the Horus nevus. Then this is pigmentation along with thickening of the skin. This is ochronosis, mainly seen in dark skin individuals who are using hydroquinone for a long period of time. On the body, this hyperpigmented lesions is the bathing trunk nevus, congenital melanocytic or bathing trunk nevus. This is seen on the back of young adults, and it is Mongolian nevus. Now, coming to syndrome number 31. Now, this syndrome is that of pigmented nodules. We discussed the pigmented patches and plaques, now nodules. So this is the junctional nevus. The junctional nevus is quite pigmented most of the time and sometimes flat, sometimes raised. This is a Spitz nevus or reed nevus. This is the histology will determine actually which one is this. Then this is a blue nevus, classically blue color, raised lesions. Then this is the pigmented dermatofibroma, very similar to the blue nevus. Now, this is a lesion which is raised as well as large in size, show color variation, and you should always be suspicious of melanoma in this case. This is a raised nodular pigmented lesion. This is a nodular melanoma. Then similar pigmented raised lesion with annular margin, it could be pigmented basal cell carcinoma, and you can see similar the pigmented BCC again. So, having done with pigmented nodules, now we are going to discuss the non-pigmented nodules, non-inflammatory and non-pigmented nodules. This is a Spitz nevus, which is can be pigmented and can be non-pigmented. This is intradermal melanocytic nevus. Usually, the intradermal melanocytic nevus are very faintly pigmented. This is basal cell carcinoma, a nodular lesions with central ulceration. So, nodulo-ulcerated BCC. There is a proper crater here in this nodule, and this is keratoacanthoma, a large raised nodular lesions, and you should suspect cancer. This is most probably a squamous cell carcinoma and an ulcerated plaque on the forehead. Again, the differential diagnosis will be SCC or BCC. Similar kind of bad ulcer on the foot, if it develops as a result of long-standing wart, it could be carcinoma canaliculatum or squamous cell carcinoma. This is not very bad, but this is a nodular skin colored lesion, and it could be any benign or malignant tumor, and biopsy will determine this is clinically this is poroma. A very common condition seen in many individuals, especially dark skin, and a especially tendency to develop hypertrophic scar. This is a little bit more than hypertrophic scar. This is keloid, and this is a dermatofibroma. Here it is without pigment, so this is skin colored nodule and a skin colored nodule which is spreading or in a form of an irregular plaque. This is DFSP or dermatofibrosarcoma protuberance. On the face, a nodule with a bit of hint of calcification, pilometricoma. Then a large cylindrical nodular lesions on the scalp. This is cylindroma, and again a skin colored nodule or papule with history of pain. This is acrine spiroadenoma. Similar kind of skin colored nodule which is painful is glomus tumor, and small to large pedunculated or flat plaques with background of capillary macule. This is neurofibroma. So there are a lot of conditions which are associated with the skin colored nodule. Now, coming to number 33, we have multiple skin colored papules, not nodules now. So, this is on the nose, a very typical site for trichoepitheliomas, a follicular origin, benign adnexal tumor. Then, this is syringoma, which is again an adnexal tumor originating from the acrine sweat coils. Again, syringoma. This is painful, skin colored, and papules and nodules, and these are leiomyomas. Skin colored papules seen on the nose and malar area, adenoma sebaceum, or angiofibromas, hallmark of tuberous sclerosis. Lots of pigmented papules on the face. These are the plain warts. Coming to syndrome 34, this is the last syndrome we are going to discuss. The lesions are cystic and there is a large cystic lesion with central punctum. This is epidermal inclusion cyst, which is erroneously called as sebaceous cyst, but these are not sebaceous cysts because they have no sebaceous glands here. So its inclusions, epidermal inclusion cyst or epidermoid cyst. Then these are the large cysts on the scalp comes in the differential diagnosis of cylindroma. These are the pilar cysts. Then these are actually the sebaceous cysts known as Steatocystoma multiplex. These are not, they are multiple, number one, and they are soft, number two. And sebaceous glands are present in the wall of these cysts. This is cystic lesions with blood. This is lymphangioma circumscriptum. So now we have come to the end of my talk, and I hope that this way of classifying and then reaching to the diagnosis of a clinical disease will help you in your clinical practice. And try to practice this and do give me your feedback. Thank you very much and have a very good day. Goodbye.